I welcome you all to the 9th webinar of ERA4Health, Strengthening the Path from Research to Practice. And I welcome Shabs Rajasekharan to speak. And without further ado, you have the space. Thank you for coming.
I hope you're safe where you are. Thank you for joining. Thank you, Shlomo, for inviting me to do this and organizing this as well. I'm going to share my screen. Let's hope that I can. Yeah. Right. So I guess you've read the brief about this. I'll explain a little bit later what I intend to talk about it today. And just even before I forget, I really don't like the sound of my own voice, so I try to talk much less and get you to talk. But obviously, in the circumstances with online, it's not that easy. So, but hopefully, I'll get through this quickly and we can have like a full discussion. First of all, thank you for answering all the annoying questions that I'd insisted on in the registration. I wanted to have a sense of what it's like for you in terms of barriers, and what the challenges are like. And my aim was actually to tailor this to that, but then I realized that if I tailor this to the majority, we'd end up leaving out all these other important bits. And for me, everything's more or less important. In practice, you can see here for you as well. It probably overlaps a lot of your answers as well. It's funny though that most of the majority actually said evidence is more evidence is, or the right kind of evidence is what you need for challenges, and that's good because I agree somewhat with that. And less on decision makers, which I would actually put as my top one. And anyway, this, as you can see, most of these are from academia. And so again, I'm not surprised that evidence comes up first, because I hope I'm not offending anyone by saying that academics actually love evidence and like to look for more and more evidence. But anyway, this is good to know. We can come back to this if you like, if you've got any thoughts on this later. Yeah, what I'm going to present is not rocket science. Most of this is out there already. I'm just trying to bring a lot of bits and pieces together. Main thing is that, a translation really depends on aligning evidence with decisions and real world systems. So, and I think that the main, if I could, sum up everything that I'm going to talk about today, it's just mainly that you ask better questions early about adoption and decision making. And they're not technically heavy questions or anything. They're some very, very logical questions about how you get something implemented. I guess the work that's required is actually asking those questions right from the beginning and continuously asking those questions. It's kind of resource intensive in a way, because you'd have to go and find the people. And you'll see what I mean as I take you through this. So just very, very briefly, I work for IESE Business School, Center for Research in Innovation and Healthcare Management, and in Barcelona. A little bit about myself. I used to be an engineer, a programmer. I would like to say a former geek as well, because I somehow acquired the skills, the social skills, to be able to explain what my code was all about, and to speak to physicians and other kinds of stakeholders without looking down at my feet. I no offense to any coders out there. I think this is really hard. I worked in medical imaging research, not really clinical research, but it was cancer research, oncology, PET CT. And I also then being fed up of research, I moved into healthcare service improvement consultancy, things like due diligence, merging two providers together, most of this in the NHS in the UK. I also was an entrepreneur for a while, a failed entrepreneur, and I also did some applied research. And the reason I've put it all over here is because right now I consider myself a practitioner. And I guess I've done a lot of things, but this kind of makes me, in a sense, it makes me a jack of all trades and a master of none. And it's also a kind of disclaimer for this talk because, you know, I have a good overview of what needs to be done. But if you ask me about any specific component and ask me to dig really, really deep, I will probably not have the answer for you. But you will certainly know where to go and check, and I can put you in touch with those right people. This session is really about why research often fails to translate, what's actually going on behind that, right? And how we can design it differently from the start. So maybe we start with a number. This is the answer. What's the question? Yeah, you've probably heard this statistic actually, and you probably know what I'm going to say. It takes about 17 years for research to reach practice. And the number is a little bit misleading. It's a great publication with the same title, I believe. And it's an average across very different journeys, right? Different starting points, different endpoints, and different systems. And actually, even when the evidence exists, less than, in some cases, there's some publications that have been written that say that less than 20% of care is actually based on research. So actually, the issue isn't just time; it's adoption. In Australia, for example, it's been reported that 60% of care, on average, is in line with evidence or consensus-based guidelines. It's not bad, 60%, but 30% is some form of waste or low-value care, and about 10% is harmful. So, what the literature shows is that we don't really understand these delays very well. They happen across different stages: trials, approvals, publications, guidelines, implementation. So the question isn't why 17 years, it's where does it get stuck? What needs to happen for this to actually be used? So I wanted to just look at a very concrete example. Now, if you remember, I haven't got a medical background, but I've picked this out of a case I've read about. And so in heart failure, we've known for a long time, over 2 decades actually, that integrating palliative care alongside standard disease management leads to better outcomes. And patients with heart failure don't follow a single linear path. Their condition fluctuates, symptoms change, function declines, there's uncertainty, and that increases. And in that context, palliative care can make real differences. There's better system control, improved quality of life, better communication, and even reduced stress for caregivers, which is not marginal, actually. It's very meaningful. And also, it's not new knowledge. So guidelines support it, and the evidence is strong. And I guess you know I'm going to say this, and yet it's still not widely implemented. Why not? So there is, if the evidence is strong, the question is why isn't it used, right? Because the barrier is not scientific. It's human and it's systemic. So clinicians are trained to intervene, to prolong life. So introducing palliative care in some cases can feel almost psychologically like giving up, right? And there's also a capability issue. So some clinicians simply don't feel confident delivering it or knowing when to introduce it. And then there's the system itself. Even if someone wants to do it, they may not have the time, resources, or the pathways to make it happen consistently. So what we're seeing here is something important, where even when evidence is clear, adoption can still fail because the system isn't aligned to support it. So I would urge you not to build even more evidence or to listen to people. In fact, I may not have mentioned this, but there's something about evidence. Every time you publish evidence, somebody always comes back and goes, "Yeah, but you know, it doesn't work for this," or "we need more evidence," or "it's inconclusive." And usually it is actually inconclusive, right? Because it's never black and white. I mean, hardly ever so, right? So evidence is like always asking for more evidence, right? And this is like, I guess, the paradox of adoption. Yeah, translation is not. It's not this translation, by the way, is not linear. It spans multiple stages. There's delays. Delays occur at different points, And like I mentioned, the speed, it's not just about speed, it's about where and why delays happen. And just to reinforce that it's not actually a linear pipeline, I have come up with a framework. But before getting to that, I wanted to just build on this paradox. And one possible explanation, which kind of drives the rest of this presentation, is whether, if we tend to start from the wrong place. So most research, I think, is what I'd call solution driven. We begin with something we've developed, is like a method, a technology, or an idea, and then we ask, what can we test? What can we demonstrate? And I think it's a very natural instinct as humans. I think we prefer to just try to solve things really quickly, and rather than focus and just sit around thinking about the problem. But that often leads to evidence that is technically strong, yet disconnected somehow from how it'll actually be used. I give some entrepreneurship classes on how to define your value proposition and how to think about the customer's needs, and they've actually learned this the hard way. The entrepreneurs, there's a statistic I always put up at the start of these classes, which is like 99% of startups actually fail, and that's because the solution they've made, there's no demand for it. It doesn't actually exist the need for that solution. So they actually focus a lot now on the need. It's part of their mantra is customer development, customer discovery, and I think that's something that we have to try and incorporate as much as possible. We have to think of this as now, what problem are we solving, and for which population, and in what kind of setting, and what's that going to bring us? And that's what we should explore, I think, because really those three things shape everything that follows, which is what evidence is relevant, who needs to be convinced, and whether adoption is even possible. So the shift here is subtle, but it's important. It goes from what we can prove to what problem are we solving, for whom, and where. So I mentioned a framework, and I mentioned as well that this isn't a linear pipeline translation. It's more iterative, and I think we begin with the need. We move on to the context, understand where and how it will be used, what evidence is then needed based on that need and context, and also the decision maker. Now, it's quite possible that you find decision makers and they tell you that they want a different kind of evidence, or that there's a context that you haven't thought about, and you have to go back and build evidence. So this is what I mean by iterative. Most of the time, I haven't put these like arrows here, but a lot of times you end up like going through. Oh, you can't see my. Yeah. So most of the time you have to do these kind of like iterative circles within this or between these components. And then can this realistically be delivered, and how will it be adopted and sustained? So I'm going to go through this, but because it's kind of abstract, what I've done is I've created this example intervention. And actually, I was looking through a lot of the projects that have been funded by ERA4Health, and this, for example, is there's a few on public health interventions like this, which is basically like imagine we're designing a public health intervention to improve physical activity and diet in children. And there's a few like this there. But I just want to say that even for those who are doing advanced medical therapy or medicinal therapy products, or biotech or medical tech, a lot of this can still be applied. Yeah, I've just focused on this because it really looks at the full expanse of stakeholders. So if we begin with need, let's start. I mean, the first kind of questions you ask are what problem are we actually solving? Who's affected, and in what way, right? And is this seen as a priority by the system? Because if it's not a priority, it's very unlikely to be adopted, no matter how strong the evidence is, and no matter how many publications there are out there. You have to speak to the locals. You have to understand whether it's a priority in the local system as well as the national and regional ones. And to answer those, you kind of like you move beyond assumptions and you look at data, for example, population trends, but more importantly, it's stakeholder perspectives. And in this example, we'll quite probably see a clear need because of rising childhood obesity, low activity levels, there'll be a higher burden probably in disadvantaged communities. So this is why I've put the equity icon here. But crucially, you've got to recognize whether it's a prioritized problem that the system is already trying to solve. Now, if we look at context is where will this actually be used? So a key question is like what systems or environments are going to be using it. Context, you've got to remember that context is not a single thing, right? It operates at several different levels, multiple levels. The individual, social, organizational, and system levels. And all of these levels actually interact with each other. In fact, most of what determines outcomes happens outside the intervention itself. I read somewhere that the patient spends like 10 minutes with the GP, but 500,000 minutes outside before they see the GP again or go back to the practice. Yeah. So a lot happens outside. And similarly, like a child might spend a short time in a program, in an exercise and diet program, but most of their behavior is shaped by their daily environment, family habits, school schedules, neighborhoods, where they live, how their background, how they grew up, their culture, access to areas, easy access to that, and what their family does at home, what they think, their opinions. And then on top of all of that, there are system constraints. So if I haven't got there yet, but quite possibly you know that this is something that you probably have to implement in a school. The schools are usually under pressure, lots of KPIs. I don't know any teachers. Well, actually, I do know teachers that have lots of holidays in Spain, at least where I'm based. But I'm pretty sure that they're bombarded with paperwork, and they spend a lot of time doing that. So they have limited time, yeah, and probably they're not very incentivized depending on where they live. There's also variation across different regions, different schools. So actually, even if something works in theory, it may not work in practice. And the key point is that if you don't understand context, you don't understand whether something will work. And this is basically around understanding, the problem, and spending more time understanding what the problem is. So I just want to make this segue here. I always ask, are you solving the right problem or just implementing the wrong solution better? Because it's easy to say, forget about your solution, but if you spend years working on it, if your PhD is based on it, if your team's PhDs are based on it, then how do you say, all right, I'm going to go back to the problem, especially when quite possibly you think that you know the problem really well because you spent decades on it. I would say, all right, try and keep that aside, and don't assume that you fully understand the need, always. One of the things that I do in this circumstance is actually I use a tool called the problem tree. Now, I don't fill this out by myself, and sorry, I don't want you to be overwhelmed by it. But basically, it's like a tree that looks at root causes, and then it looks at the consequences as well of those problems, the causes. Yeah. Most of the time, you can't find causal mechanisms from the root to the consequences, but certainly there's a lot of correlation in some of these. So I do this problem tree with all the stakeholders that are affected or impacted by the actual problem or the intervention, or when they come in contact with it. Yeah, and some of them are more direct than others, but it's much richer if you do actually work on this together, co-design it together. So it's resource intensive, but it's worth doing. So I've kind of just done one route and one consequence here, and if you look at it, you'll see. So, for example, if we ask children why they're inactive, they will probably often, like we often stop at maybe behavior time, especially screen time, and their behavior, and right. So now, because of the fact that social media problematic social media use and all of that is in the news, and it's on lots of parents' head. But actually, if you dig deeper, you see that it's probably a lot more to do with that. Family constraints, lack of access to safe spaces, ultimately environments that don't make activity the easy choice. Things that I put up earlier on about, like what may affect an intervention. The thing is that if you don't dig deep enough, you end up building for the wrong problem. And this is what I meant. I've already seen digital solutions trying to reduce digital time and getting children to go out. Maybe there's something there that they're trying to tackle, but I think it's partly because they've probably stopped here and they've not gone down there, dug deeper and asked why several times to get to the root cause of the problem. And focusing on the root cause of the problem, I think, has much more impact than somewhere up here. So we've looked at need, we've looked at context. How about evidence? Now, I don't think I need to talk a lot about evidence here because, especially with academics and clinical researchers. But when you think about evidence, we usually focus on one thing: does it work? Clinical effectiveness, statistical significance. But for real-world use, I don't believe that's enough. The real question is, does it work in the real world across different populations and in a way that matters to decision makers? And that is, for me, the most relevant. It's what the decision maker wants. I think we've been told a lot, especially those of us who write or who are from academia and who probably submit a lot of proposals. Horizon Europe proposals, that you need more and more evidence. You need evidence, or sometimes like I remember 10 years ago when working on this about barriers, and the top barrier was always not enough evidence. That's why it's not being adopted. And I think, like I mentioned before, there's not this obsession to keep building more evidence. But we have to remember that clinical trials, it only tells us what works on average. And regardless of what evidence there is, the decision maker doesn't really care about that evidence sometimes. And patients are not average, so probably that's one of the reasons why they don't, right? We have to remember that real world settings are not controlled environments. And perhaps this is where a lot of projects fall short, because it's scientifically strong but not usable. And that evidence has to be usable. So it needs to go beyond efficacy. It needs to think about, does it improve lived experience? Is it acceptable? Is it easy to use? Does it actually support decisions in practice? If you've got evidence, will a clinician actually base their decision on it? Will they act on it? And does it fit the context in which it will be used? And this has also been one of the reasons why there's been a rise in real-world data, or the need to have real-world data, actual evidence from delivery settings, engagement, adherence. And these are all early signs on feasibility and scaling as well, which we'll talk about later. So the shift here for me, the main thing to keep in mind is that we need to move from evidence is publishable to evidence that is decision relevant and usable in practice. Regardless of what your KPIs tell you, which could be publish more, make more patents, etc. But if you want it to be used in the real world, we've got to think differently. Otherwise, we risk just generating more and more knowledge that can't be used. So I want to do a quick segue here into interviews. it's big. Well, I think it's important because I've been saying, you've got to find out about this from decision makers. You've got to speak to stakeholders. You've got to interview them. Well, I think it's important to understand how to do ask the right kind of questions and find the right kind of people to ask. And then we'll come back to the framework. So if you ask questions that assume your solution is right, you will get polite validation, not the truth. And a lot of times we are so in love with our interventional solution that we just want that validation. Again, something I think that's very human, right? So try not to explain the science, try not to pitch, okay? Try to remember that this isn't about you. It's about the end beneficiary. So there are some wrong type of questions, which I had before this, but which I usually put up, and I get people to tell me whether they're wrong or right, but I'm just going to go straight to the right ones. So oh, sorry, I see that I've got an example for epilepsy, and that's because it was an example I'd used before. But essentially, it's when you speak to clinicians, when you ask them if they have the time, and which is unlikely as well. But if they do, then it's about, rather than asking yes or no questions or yes or no answer questions, it's about walking through what they do and how they treat somebody, how they make a decision. You want to find out what kind of information they need to make a different kind of decision, or what they do for the existing one, right? Regulators, it's very much the same point. What kind of endpoints are you looking at currently? Is it hospital readmission, or is it something else? And if you can, I think sometimes it's public. You can find things that are public, like about why submissions have failed. It's good to know as well. I've also got pharma and partners here in industry. Obviously, in this public health intervention, it doesn't really fit in that much, but I wanted to bring this in because I know a lot of you do this, like medtech and biotech. So first of all, finding the right person from pharma is in itself a really hard thing to do. Okay, finding the time from the right person is also hard, and getting them to answer honestly, I think sometimes it's also difficult. But it is good to understand why something wouldn't work for them. And I think I've got that later here as well, about trying to find, how your thing is going to fail as well is a really good way to get the right information. So observations are really, really good as well. In fact, I think a lot of times they're better than interviews. But obviously it's hard to access, right? But I don't know, I often think that if you're part of some kind of an ecosystem or some kind of innovation ecosystem, usually this is what they should give you access to, even as an academic. And a lot of times, a lot of academic research, clinical academic research has a clinical research scientist that's affiliated to the university and also to a hospital. So this is where you've got to work with them to do this kind of observation. Regulatory observation, I'm not sure how feasible it is, but again, it's well worth the try. Yeah. And obviously commercial observation, I think this is really hard because a lot of these things are secretive, or they're not very transparent either, and behind closed doors. But again, this is all about trying to see how these decisions are made. Also, remember that when you look for people to interview, don't find your friendly key opinion leaders. Don't wait until your CTA, your clinical trial application, to start talking to them. Always do things earlier if you can. So I'm not going to go through all of this, but the main thing is that if you talk to the people around you in your network, you almost always hear the same thing, that it's interesting and it makes sense. But those conversations are like, you've got to have those kind of, those conversations that you have are happening in a kind of like shared context, right? They have the same training, they have the similar kind of incentives, and they have a similar worldview. So you're not really testing adoption. What you're testing is alignment within your own bubble. And real adoption pressures come from outside that bubble. So if you can get out of the bubble, it's much better. And I actually like if you seek out people who don't want to speak to you, I think it's better if you can, obviously. Like clinicians who say they don't want to run your trial, they think it's a bad idea. Go back to them and ask them why, find out why exactly it's a bad idea, why they wouldn't do it, why they would want to do it, regulators who don't want to approve your solution, or understanding regulators who don't like approving these kind of solutions, and partners who won't license it either. And this is where you'll really do some proper learning, I think. It's the difference between something that is interesting and something that is actually usable. Right, I mentioned as well, don't wait too late, because actually what happens is then it gets harder and harder. The longer you wait, the more expensive it becomes for you. You find that your asset doesn't fit your portfolio, your endpoints are not the right ones, its maturity is mismatched. It's not the best thing to do to leave it all early. And a lot of times people do, because they feel that, right, I've got some time to get to it, and when I have everything ready, I'll go and speak to a regulator. But actually, you should just do it right from the beginning, from day one, when you have this idea, or when you've understood the problem. So getting back to that framework, decision. So this is really where things become very real, right? Because impact doesn't happen when something works. It happens when someone says yes. The really hard thing is actually finding out in health who that person who says yes is and how many there are. And I admit that navigating the health system is really tiresome and frustrating. So I wouldn't be surprised if someone said, "How do you find the right person?" And I haven't got a clear answer to that either, apart from just trying. In most of these cases, it's not one person. So if we look at this, we go back to the public health intervention example, right? There are multiple actors, right? There's local authorities, usually who fund schools, who decide on what to do with the schools. There's school leadership who decides how to implement it. There's parents, there's community stakeholders. Adoption now becomes a coordination problem. And each of these actors is evaluating the intervention differently. And in this case, some of the actions or some of the decisions actually come down to very few kind of key criteria, like does it align with existing policy priorities? What does it cost? Not only in money, but also in time and resources. Can it realistically fit into school schedules? Because if it disrupts the system too much, it won't be used, right? And then beyond the formal criteria that people will give you, there's also things that may not be quite transparent initially, and things like perceived burden on staff. The invisible or tangible benefits for students, and whether these things align with programs already in place. So it's why we really need to explicitly map who decides, how decisions are made, because without that alignment, strong evidence alone is not enough to get the yes. So I mentioned about navigation and complexity, but it's most markets value is really simple, because when you have to understand what the value is for others, right? And it's simple to say that in other markets, because the innovation adoption usually depends on user, but in health it's an alignment of multiple stakeholders, because that value is different for different people. It depends on who you ask, right? So, for example, families, the value may be about daily life and ease and well-being and engagement. For schools, it might be, does it help learning? Local authorities, it may be coordination and resource use. Local authorities are always the ones who get their budgets cut, during a crisis, financial crisis. And for policymakers, could be more about cost effectiveness or population impact, or also budgets, the intervention can be seen as highly valuable, but it depends on the perspective. And the risk is you optimize for one with the definition of one definition of value, and unintentionally you fail others. And this brings us back to this thing about alignment, because success depends mainly on designing something that works across these lenses, not just one. And at IESE, we've got this tool called Align that helps with this, and I can talk a little bit more about it later, but it's basically a role-playing game where we get to empathize with the other stakeholder, understand where they're coming from, and it basically creates this kind of structured space, like a simulation, but it's not a computer simulation. It's a role-playing game where different stakeholders can express their constraints, challenge assumptions, and negotiate trade-offs. And basically, at the end of it, you kind of, I guess, you see a different point of view, and you understand a different point of view. Right. I've got a few more slides, and these two, feasibility and implementation, are the last two now. So feasibility is where, like your idea actually begins to collide with reality. So up to this point, something might look promising on the paper, but then the harder question is, can it actually work in the environment you're going to implement it, right? Like time pressure, I kind of mentioned, burden on staff, competing priorities. These are like, the goal here is not just to identify barriers. And in fact, there have been a plethora of papers and publications that have identified barriers. But what there's been less of, I think, is strategies to counter barriers and how that has worked out. So, you identify the barrier, but think of the strategy of how you're going to mitigate that as well, and then try it out. Because it might actually mean adapting intervention. Now, I'm not going to get into this too much, but I know it's complicated to adapt in a clinical trial or an RCT once it's already going. I think there's some work around there about learning as you go, but I'm not really an expert on that. But I think there may be some space for some small changes. But yeah, if you can design for it earlier on, better. And then there's implementation. So if feasibility is all about can it work, implementation is about does it actually happen. And I think a lot of times fundamentally it's about behavior. Who needs to do something differently? How often? Under what conditions? And I think an insight here is that adoption is not a one-time event. It's something that needs to be supported over time through simple processes, through training, through feedback. A lot of times we do these grand projects that finish in year 4 or 5, and then after that we don't think about what happens afterwards, or we can't because we've run out of resources. But really, the idea should be from the beginning to think what's going to happen after year 5. How am I going to keep this going? What am I going to put in place until year 10? Even though I'm not going to be there, maybe it'll be somebody else who takes it over, or there won't be any funding. It's got to really stick. If you put something into an existing routine, it's got to stick, and you've got to understand what the levers are to make that stick. So I'm going to try and summarize maybe some key points. A couple of things. Where do things usually break? When there's no clear decision maker. I think it's really great if you ask that question right from the beginning. Who's going to decide whether this becomes routine care? Who's going to decide if this is going to sustain after grant funding, for example? What kind of workflow mismatch is there? A lot of the AI tools at the moment there's a lot of AI tools being pushed, and I think there's always this bit, and everybody knows this, right? There's a bit where you apply the tool where it's just excessive amounts of work initially, more work for a clinician And then there's always this, they say, you know, you always got to start off with like that, but then better off later on. It will, you know, it will come down later. But there's still this big, huge amount of burden at the beginning. And who wants to do that? You know, who's going to accept that with the idea that hopefully somewhere down the line in like, you know, a year's time, it's going to get better. I think these are things that have to be addressed earlier on. There's also a lot of incentive misalignment, which I've mentioned, and I think it's really important to identify those incentives and then get people together so that they can align together. And then there's this thing about implementation burden. I have to say, after all of this, actually, even asking questions sometimes can feel like a bit of a burden, because I'm pretty sure that none of these questions, it's not the first time, you know. I actually sometimes reluctant to even start workshops talking about barriers, because I think that, you know, especially those in health, have just heard this so many times over the last 50 years that I really worry what they're going to say when they see me walk through the door. But anyway, I don't have a better answer to that. So yeah, so in summary, 6 questions to ask very early. If you remember nothing else from today, are we solving a real problem? Or is it just an interesting one? Does it fit somewhere real, or only in a controlled setting? Are we generating evidence for publication, or is this for a decision? Do we know who actually has the power to say yes and why they would? And even if they say yes, can this actually be delivered? And then what will make people actually continue using this after the first pilot? So if you ask these early, you don't just reduce risk, you fundamentally change how you design your work. I've just got just 2 cases that I wanted to present. Again, I'm not an expert in either of these, but I think this is really interesting, right? It sort of throws everything I've just said out the window, in fact. But it's good to know that, you know, none of this is rigid, what I've explained, and you'll often find that if you do everything even out that I've talked about, you're still probably going to end up with the same thing. I'm sorry it's pessimistic like that, but you know, it's a very complex system, as you know. So HPV vaccinations, this is a good success story, yeah. But if you know anything about this, like evidence or work on this began in the 50s, I believe. There was in the 70s when they started finding causal links to cervical cancer, for example, there was it was a well-defined population for testing. There was alignment with governments, WHO. There was delivery would have been built in via schools. But a really interesting point that I read about here is that you know, it was easy to convince researchers to do HPV research, and academics, clinicians, but not industry. So you know, it was really kind of surprising, but I guess they didn't find the right business case for it, and they've looked at it as a huge risk. So it took them a very long time to get industry engagement. But actually, you know, the success here is that it came from an alignment across evidence, policy, funding, and delivery. Now, in contrast with robotic surgery, I'm not going to mention the companies, but adoption was really rapid. If anyone out there is certain with robotic surgery or understands robotic surgery, you'd know this. You know, I remember reading about this very early on, how the best players in the market entered even before evidence came out. And why? Because actually adoption was driven by really strong perceived advantage, especially in the US, you know, patient demand. I've read there's actually a really good New York Times article on this, where, you know, a lot of hospitals, patients would ask hospitals, have you got robot surgery? And if the clinician said no, then they'd be like, okay, bye, I'll go somewhere else. So, you know, there was a lot of patient demand in that sense. And then there was competition between hospitals. So the system moved before the evidence was fully established. And in fact, now, if you look for publications on robotic surgery, you find that nobody can agree what the right evidence that needs to be collected is. They're still arguing over what kind of evidence they need. But there's more evidence today. So anyway, I wanted to mention that actually you can jump a lot of those components. I'm not saying you should, but but you know, I'm not advocating for it, but certainly you can, and then things are very non-linear, and things are the framework I presented should not be taken rigidly. So if we want impact, we need to understand not just what works, but what drives that adoption. And that's all I have. I'm happy to open up for any questions. I'll just give this a rest. Hope you're all still there.
Thank you very much for this very interesting talk. I will stop the recording and then we can open for discussion.